My name is Alvin Moyer. This is Varun Doddapaneni. As Michael said, I work at Elizabeth Seton Pediatric Center. Varun was a fellow who rotated through our center as part of his pediatric training. We both practice in hospice and palliative medicine, I in the pediatric world and Varun in the adult world. We are thrilled to be here, and I really thank you for many, many things. The first is, as a clinician who works with children with rare and genetic diseases, we really appreciate everything you do and the sort of behind the scenes and not always in the limelight of medical research. And I say that not just as a clinician, but also as the brother of two siblings who died of rare neuromuscular diseases. So I appreciate everything. We titled our talk, "A View Through a Different Lens," and the reason we're so appreciative of being here is that we appreciate the opportunity to show a different view, a clinician's view of what it's like to care for individuals, and in particular children with rare and genetic diseases. And we're doing so from a palliative care perspective. And if nothing else, we hope that you will begin to understand what palliative care is. It's a relatively new field in medicine. Identify that it doesn't just mean hospice care, it's not just end-of-life care, and that we can be involved and oftentimes are involved in rare and genetic diseases through what could be a lifetime for these children. I'm going to start with a quote from the father of one of our children in the center who I was not involved with his daughter's care when she was born, but she was born with a very rare chromosome deletion syndrome. And at the time that she was born, the family was told that she would not likely survive to see her first birthday. He's a local television and radio personality who you may know, happens to have this daughter who I sat down with them when she was 16 years old, and we had to plan for what was going to happen when his daughter aged out of our facility and needed an adult care. They weren't prepared for this because 16 years ago they were told she wasn't going to live. And that story is a very commonly repeated theme. So what is palliative care? To understand what palliative care is, I wanted to go back a little bit about its history and where it came from. And the field of palliative care really came out of the hospice movement in England. In 1967, a woman by the name of Dame Cecily Saunders, and if you Wikipedia her or Google her and read about her, she's a very interesting woman. But she created the very first purpose-built hospice in the world. That's St. Christopher's Hospice in London. And I say purpose-built because obviously people died before 1967, and there were people caring for those dying patients, but this was the first time that somebody took an academic approach to the care of dying patients and built a hospice program specifically for that purpose. In 1969, Dr. Elizabeth Kubler-Ross published a book called On Death and Dying, which was, I think it's still read. I read it in college. I was asked to read it in college. It's still commonly read in academic circles in psychology, and was a very comprehensive and academic look at death and dying. She interviewed thousands of people who were actively dying and their loved ones in the bereavement. And again, it created a sort of a movement, if you will, of people recognizing that there was a underserved area of medicine and paying attention to people who had life-limiting conditions. It wasn't until the mid-70s that we got our first purpose-built hospice. That was right up the road in Connecticut on Alpha 95, the Connecticut Hospice in 1974, which was also the year that the term palliative medicine was coined by a urologist in Montreal. So where did he come up with that term? Well, actually the root comes from pallium, which is Latin for cloak. So a cloak that we wear, and we can see that the connotation suddenly becomes one of sort of enveloping, comforting, providing warmth. Feel touchy-feely. the World Health Organization defines palliative care in a very wordy definition that I'm not going to read word for word, but I want to emphasize some of the key points that the branch of palliative medicine aims to improve the quality of life, regardless of what's happening with the quantity of life, right? So how long I live is not the primary concern. How well I live is the primary concern. And we do so through the prevention of symptoms and treating aggressive management of symptoms. This old model, because palliative care came out of the hospice movement, originally palliative care was really just reserved for children, or for individuals, not children, individuals with terminal illnesses. And it was provided when curative therapies were no longer either offered or available or indicated. It was therefore almost exclusively associated with hospice. And because children, until recently, children aren't supposed to die, right? Children don't die. That's just a thought process in medicine, even today. And if you start with that assumption, then hospice would not be available to children, it would be offered to children. And many hospices today don't accept pediatric patients. So this old model is kind of a graphic representation. Is if I'm an individual diagnosed with, say, small cell carcinoma of the lung, I'm in my usual state of health, I'm diagnosed with this problem, I start chemotherapy, I get sicker and sicker and sicker. After a couple months, very stereotypically, the doctor walks into the room and says, there's nothing more I can do. We're sending you to palliative care, we're sending you to hospice. And that completes my curative-based therapies. A line is drawn in the sand, and now I move on to palliative care. And eventually I die, and there's this bereavement, and everything is there's delineated. Now, obviously that has shortcomings, and we'd like to share and hopefully convince that palliative care really is available and should be available to anyone suffering with a serious or life-limiting condition. It can be offered in addition to curative therapies, curative-based therapies. Palliative care does not equal hospice care. It can include hospice care, but it's not synonymous with. And pediatric palliative care is now a recognized and board-certified discipline. So we've advanced over the years. This new model, although this representation isn't perfect either, but this graphic representation of where palliative care can be evolved from the very beginning. And its role in the beginning may not be very major, it may be a very minor role, but as the disease progresses or as symptom burden becomes heavier, palliative care may become more and more involved and more important to this family. One shortcoming of this model is that palliative care does not end with death, and certainly our services are provided to families even beyond death and throughout the bereavement process. The World Health Organization goes on to define pediatric palliative care a little bit differently. And again, I'm not going to read the whole definition, it's very wordy, but I'm going to highlight the areas that this is active total care. And what I mean by that, or what they mean by that, is this is care we are actively providing. This is not care we're withholding. Okay? So we sometimes hear that, right? We're not going to offer chemotherapy because it won't work anymore. We have nothing more to offer you. Well, that's not providing palliative care, that's providing no care. Palliative care is active total care. So one of my personal pet peeves is to hear the words, there's nothing more we can do. So there's always something we can do. Something we can do. I can make you more comfortable. I can make this experience less obnoxious. I could just sit with you and be present. It's all something, right? It's all something. So it involves giving support to the family, and that's important, is that, as Michael told in his personal account of his son's illness, it affects the whole family. You were captive for 135 days? 33 days. You were captive, and we have to appreciate that this illness infects the whole family, and our services can be provided to ease that burden for everyone. And it can begin when the illness is diagnosed. It continues regardless of whether or not people are receiving curative-based therapies. And lastly, it involves a transdisciplinary approach. So you'll see in the slide a little bit that we have a lot of different disciplines involved in our facility. I threw in just some entertainment slides, hopefully, of children actively involved in activities at our center, just to show that my talk may be like a Debbie Downer, but actually our place is a very happy place. It's not a sad place when you enter our facility. So who are we? We are a 169-bed pediatric chronic care facility. Currently, I think we have about 59 ventilator-dependent children, but that varies from day to day, and who gets discharged and who's here and who's not. We provide both comprehensive rehabilitative and palliative care, so not everybody comes to us for end-of-life care. That's not what we are. We are not a hospice. We provide physical therapy, occupational therapy, speech and language pathology, music therapy, art therapy, recreation therapy, hydrotherapy. We have a school on site as well, so most of our children, virtually all of our children, go to some form of school or early intervention. And these are just a few of the diagnoses categories that we deal with, and I highlighted some of the areas that might be of interest to people in the room, which are diseases which carry can be rare genetic diseases. We see a lot of very intractable epilepsy, seizure syndromes. Many kids with neurodegenerative processes. These are Bacon's disease, the adrenoleukodystrophies, that's the Lorenzo's oil diseases, inborn errors in metabolism, genetic syndromes that are like chromosome either trisomies, chromosome duplications, chromosome deletions, as well as congenital myopathies or muscular dystrophies, all very well represented. We have some very rare diseases, and as you are about to find out, we're going to describe a child with a disorder in which it was only just ever described in 2 other pedigrees in the literature. So really no evidence to go on to guide her. This is just a graphic representation of showing our patient population compared to a national study that looked at who is referred for pediatric palliative care, who receives pediatric palliative care consults. I don't want to explain it too much because the first thing you're going to say is like, these lines add up to more than 100% because that's percentages. And the reason is because the original study, if the children were affected with a neuromuscular disease or something from birth, they counted it as congenital and whatever else, which I wouldn't do. I would probably limit this, but what I will say is that our data pretty much matches the national data very closely in terms of who is referred for pediatric palliative care services. So we are essentially a palliative care center. This is just a Venn diagram showing that it doesn't matter why the children come to us, that oftentimes our goals of therapy or goals of care evolve with time. And just as that father who I was sitting with this family at age 16 had been told their daughter was going to die before her first birthday, their goals of care sort of evolved over time. So it was no longer end-of-life care. Now we were planning long-term care. So what are some of the challenges that we face? Well, the first thing I would say is that you could tell from our previous slides that we have a very diverse patient population. Even if they look kind of similarly, you see a child in a wheelchair, they have a G-tube, they may have a trach or a ventilator, they actually represent a very diverse patient population. They have a very diverse problems, diagnoses, and because of that rarity, we don't really have very good prognostic tools to guide us. If you think about the adult world, adulthood has about 100% mortality, right? Approximately 100% of us will die. And statistically speaking, most of us will die of one of 4 disease processes, either cancer, advanced cardiovascular disease, advanced pulmonary disease, or dementia. Those 4 broad disease categories account for the overwhelming majority. So Varun's job is really, really easy compared to
Absolutely.
No, what he does have, though, is there are more prognostic tools to guide adult clinicians in how to predict death or predict prognoses. And we just don't have that in pediatrics. To a certain extent, it's gotten better over the years, but to a certain extent, we still do encounter just family stigma associated with palliative care and this concept that palliative care is giving up, right? It helps in that when we admit children to Elizabeth Seton, every child is admitted with a palliative care plan. So we tell parents that our palliative care plan happens for every child that's admitted. So it becomes not something that's specific to their child. They kind of get a sense of that this is a routine and this is something that's part of a bigger community. To some extent, there are still a lack of resources. I must say I'm very spoiled at Elizabeth Seton because we do have a commitment to palliative care. And so, for instance, we have at least 5 full-time music therapists and 2 or 3 art therapists and recreation therapists for every neighborhood, and we're committed to that. But in a hospital or an acute care setting, and certainly in a for-profit medical model, you can't bill for those services. So especially with pediatric-related services, they're not billable. Oftentimes, acute care hospital may have a music therapist, your hospice may have a music therapist, but it's more often grant funded, and if that grant dries up, that music therapist loses their job. So again, our current model of healthcare doesn't necessarily support these sort of complementary or alternative therapies. And then obviously, we're dealing with children, and children aren't making their own decisions generally, and that sometimes causes some ethical dilemmas. We learn to deal with those on an almost daily basis. I'd say the biggest challenge that is illustrated by this case that I'm going to hand over to Varun shortly is that children are living longer with what were once thought to be fatal diseases, and palliative care has a very real impact on that. Why are they living longer? Well, first of all, I would say regarding the child that I was referencing in the beginning of the talk, many of the diseases which we deal with are, again, so rare that there really are not any accurate information on prognosis. So they're often offered inaccurate or outdated information. But I'd say the most important reason is the last on this slide, and that most of the diseases that we deal with in our center, the children don't actually die of the disease itself. They die of complications of the disease. So it's not their needle and rod myopathy that has caused them to be ventilator dependent and unable to move. It's not the myopathy that kills them, it's the aspiration pneumonia that they've gotten for the 12th time with now a lot of scarring in their lungs, or it's the influenza that they got, or it's an infected bed sore, not at our center, but somewhere else. An infected bed sore that develops into sepsis. So it's complications, and if we can prevent those complications, we actually help them, their comfort, we actually help them to live better, and we actually cause them to live longer. So again, a really strong focus of palliative care is symptom management, and the fellows that rotate through our center spend about a month going over this slide, doing nothing but this slide. And so we could talk forever, and that's not the point of this. But just know that, again, with a very diverse patient population, you have a lot of very diverse symptom management issues and concerns. And it involves a very transdisciplinary approach. So every member of our team helps us with this symptom management. And this is our interdisciplinary team. So this is our palliative care committee at our center. And you can see that it's a pretty inclusive committee. Some of the themes that we deal with are, again, Michael, your talk, your story with your son illustrated a lot of these key points, and that what our families go through is very difficult to characterize. So even if you read On Death and Dying by Elizabeth Kubler-Ross, she doesn't necessarily talk about children with rare genetic syndromes and what families go through. And the first thing that I would say is your mourning process began when the diagnosis, when you first heard that diagnosis, because you lose this sense of a childhood ideal. They may not be mourning the loss of their child, but suddenly all the dreams, the thought of graduating from kindergarten and riding a bike for the first time and playing Little League and graduating from high school and walking your daughter down the aisle, or all those thoughts that you had, you may need to revise, right? And there's a sense of loss with that. In addition, many of our families face this sense of anticipatory grief because now they're told that this is a life-limiting condition, and at some point, you are going to outlive your child. Right? So you anticipate that. Now take that and say, it's not happening over 2 months, it's happening over 2 years, maybe 2 decades, maybe longer. And it's impossible to keep up that same intensity of grief. Combine that now with this emotional roller coaster. I can't tell you how many times I've called families and said, I think you need to come in. Johnny's not doing so well. I think you want to be here tonight. And Johnny gets better, and the next day you're like, oh, sorry. They feel great about that, but that emotional roller coaster kind of takes its toll. And like I said, after 2 decades, you can't keep up the same intensity of grief. You also can't visit your child perhaps quite as much as you want to because life goes on. And we need to work, right? You can't have health insurance, right, without working. Somebody needs to be working. And sometimes there's a lot of very complex feelings, and for some of our families, that includes if you've ever taken care of somebody who's actively dying, it so encompasses your life that when finally the inevitable happens, it's like a weight is lifted off your shoulder. And there is a sense of relief, right? And nobody talks about that, and I think a lot of families experience it and feel guilty about it, but particularly with children. And also remember, we're dealing with a lot of genetic diseases, and just to hear the word genetic for some families implies a sense of guilt. They hear the word hereditary and automatically assume it's their fault. They gave this to their child, even though we know in this room that's not the case. So I think what I'm going to do, I'm going to summarize my points, and then I'm going to hand it over to Varun, who's going to talk to you about a specific child in our center with a particularly rare disease. I want to just mention palliative care, remember, is a holistic approach to medical care. Holistic looks at the whole individual and the family. Holistic that seeks to promote comfort and minimize suffering, and it involves giving support to the whole family through a transdisciplinary approach. And it begins at the time of diagnosis and can be provided concurrently with curative-based therapies. It actually improves patient outcomes, and this is a point that I want to emphasize, is that palliative care is not giving up. And in fact, the presence of palliative care has been in evidence-based journals shown to actually prolong life over folks who receive only curative-based therapies. Right? So the presence of palliative care can actually prolong life when compared to people who receive only curative-based therapies. And for many rare diseases, as we are talking about today, that grieving process begins at the time of diagnosis. So, hand you over to Varun.
So I'm going to present a case of a baby girl, AJ, just to kind of briefly summarize how I got involved. Again, as Dr. Moyer mentioned, I was in training for my fellowship for hospice and palliative care at Lincoln Hospital in the Bronx, and part of our education includes a 1-month rotation at Elizabeth Seton. And I think one of the first days that I joined Dr. Moyer, he kind of assigned me a project, basically, learn a little bit about this baby girl, learn a little bit about her disorder, and try to help come up with a strategy to address some of her symptoms. So AJ is now a 10-month-old infant. When I met her, this was back in April, she was about 5 months old. She, again, is an infant. She was diagnosed with a congenital disorder of glycosylation, type 2E. It's also called COG7-CDG. Bear with me as I might keep going back and forth in which name I use, but COG7 is the subtype of the glycosylation disorder that she has. So her condition is characterized by a kind of a gamut of symptoms from growth retardation, progressive microcephaly, hypotonia, hyperthermia, feeding problems, tonic posturing, neurologic irritability, and I kind of highlighted the issues that were the ones that I was looking at trying to address a little bit more, because they were the active issues that we were trying to help manage with AJ. So that was the hyperthermia, the tonic posturing, the neurologic irritability. So this is a kind of child that it's difficult to say what, chicken or egg. Is she getting these wild spikes in fever that then lead to neurologic irritability, or is she getting irritable and then that leads to these hyperthermic episodes? But needless to say, we were trying to get these symptoms under control. So just to get into the disorder that she was diagnosed with, so a little bit of background. Proteins can undergo different forms of post-translational modification within the cells, within the endoplasmic reticulum and the Golgi. This is like biology 101, so bear with me a little bit. But about 70% of all proteins that are formed in the body are at some point glycosylated. That's the form of post-translational modification that occurs. And so then these glycoproteins that are formed then serve critical roles throughout the body in metabolism, including protein folding, cell recognition, cell adhesion. They play a vast variety of roles. So with CDG, there are many different types of CDG involving defects in biosynthesis, transfer, and remodeling of the N-glycan. There are over 200 to 300 genes that are known to be involved in glycosylation, and that's about approximately 1% of the human genome. Most of the types of CDG that are caused by mutations in genes involved in the glycosylation pathway. So there's now more and more other subtypes of CDG that are being found, and a growing number of them are of protein deficiencies which indirectly affect glycosylation. For example, in defects in the conserved oligomeric Golgi complex. And so that's what, when I say COG7-CDG, that's what we're referring to, the conserved oligomeric Golgi complex. And I'll get into that in a second. And again, throughout our presentation, we have interspersed a few pictures of children. We unfortunately don't have a picture of AJ herself, but continue on. So again, the COG-CDGs, they're broken down into two types. Type 1 is the more common type. It's involved in the biosynthesis and assembly of these dialcohol-linked glycans, the sugar molecules that become the precursors for in the cytosol and in the ER, and they're transferred to the proteins. And then type 2 is the less common form, and it involves processing the protein that's already bound to the processing of the protein-bound glycans in the Golgi apparatus. So just what does that mean? Type 1 is a defect in the polysaccharide assembly and transfer onto the protein, and then type 2 is some sort of defect in polysaccharide trimming and processing after it's already been attached to the protein. The COG complex, again, in the Golgi is a complex that consists of 8 subunits that form a bilobe structure, and the mutation that AJ has is in COG7 subunit of the 8. And mutations have been identified in 6 of the 8 subunits that are involved in the COG complex. So again, clinical manifestations for these type of diseases, similar to what AJ had, which was dysmorphism, skeletal dysplasia, hypotonia, hepatosplenomegaly, jaundice, cardiac insufficiency. You can have recurrent infections and epilepsy. And as Dr. Moyer mentioned, of the subtype that AJ had, the COG7-CDG, there are only 2 documented cases in literature of infants, and both of them were of Moroccan descent, and both of them died within 3 months of life. So, so when I'm trying to find out what can I learn a little, about AJ's disease, what I learned is that these two infants that passed away and were published in literature, they had a lot of the same type of symptoms that she had, and more importantly, what was the reason for their death? It was that they died due to infection and cardiac insufficiency. Those are the reasons that these 2 children died. So getting back to AJ, so how do we provide evidence-based medical therapy for AJ, and why is it so difficult to gather data regarding treatment of these rare diseases? So first, define the problem. Rare diseases aren't rare, as we learned already in the previous presentation. There are, I found 6,000, but 7,000 is another good number that just basically shows that there are thousands of these type of rare diseases. The CDG, the umbrella, of CDG, the most common type is called type 1A. It's a gene defect in PMM2, and of that there are only 800 diagnosed patients worldwide, and that's the most common. So if you think about it from that extent, all of these subtypes would fall well within the ultra-rare definition. So again, barriers for research. We kind of touched on these before in previous presentations. It's difficult to recruit patients due to the rarity of the disease. There's an incomplete understanding of the natural history to inform any sort of trial design. And again, you require, because of the rarity of the disease, there's a need for multinational randomized clinical trials, which is just really difficult to set up. So again, how do we help AJ when there's such a lack of data regarding COG7-CDG? So when we first went through this process, my first thought was, well, what other subtypes are similar to hers? And maybe we can generalize the data from the other subtypes. So again, like I said, there's insufficient data regarding COG7, but we can look at similar phenotypes. So there's an article that was published regarding patients with COG5 CDG, which is, again, a little different than the COG7, but as you remember, the COG complex is formed into 2 lobes. COG5, 6, 7, and 8 are part of the second lobe, so they kind of, both of those genes are involved in the same, both subunits are part of the same lobe. So our thought was maybe we can generalize the results that we saw with COG5 CDG. It's a little different in the sense that these patients were diagnosed later in life and they actually lived to be older. These 5 patients were between 6 and 14 years, but they had some of the same type of issues that AJ has, which is severe epileptic type symptoms and myoclonus. And what was we looked at the data and we found that there were different types of therapeutic strategies that were used for these 5 patients, and And we thought, well, if these therapeutic strategies work for these patients, maybe we can then generalize that information to better help us in treating AJ. And I'm not going to go too far into this, but this is just a kind of a list of the type of anticonvulsant therapies that were being used for these kids. And the thing to remember is that even with these children, and even with these pretty substantial amount of medications in their regimens, their epileptic activity and their convulsions persisted to varying degrees throughout them. There was no single patient that had complete control of their symptoms. So how do we use this data to support decision making? So when I first started my rotation, AJ's medications included Keppra, diazepam, and morphine. And as we changed her treatment plan and kind of optimized her medications, we increased Keppra based on weight-based dosing. We changed diazepam to clonazepam, changed morphine and transitioned to methadone, added baclofen. And the important thing here, and this is really where the difference between Dr. Moyer, who's been practicing in the pediatric world for years, and me as someone that's still just coming out of training and much more involved in the adult world. If you look at the clonazepam, for instance, that's a huge dose for a child, for an infant. First of all, there's not a whole lot of data for dosing for infants, but more importantly than that, these are enormous doses. So if I were, for example, the attending, I would have serious reservations because I would have never thought to use a dose that high. And it was more so because Dr. Moyer had some experience with using these type of medications and these doses that we were able to try and see if this helped. So what's next? One of the things that we were able to do was, just kind of getting back a little bit, AJ came to Elizabeth Seton at the age of about 2 months. She came from Cornell Medical Center, and when she was discharged from the hospital to Elizabeth Seton, she was given a 3-month follow-up. And as I mentioned before, the data says that most patients with this subtype, the other 2 patients died within 3 months. So to a certain extent, the 3-month follow-up that they had given her was kind of just a routine follow-up, not expecting that she would actually realistically be alive to come to that follow-up. So when we contacted Cornell, they were very much interested in learning a little bit more, because this kind of throws what we know about this subtype of CDG and the kind of prognostic information that we have. It kind of throws it out the window. So we collaborated with the neurologic and genetics departments at Cornell, and with the parents' consent, a skin biopsy was performed. This happened back in June of this, just a couple months ago, and or just a month ago, and the tissue sample was then divided, and the plan is to send the samples to the Ross laboratory, run by Dr. Elizabeth Ross at Weill Cornell, and to Dr. Hudson Fries at Sanford Children's out in La Jolla. And just a little brief background on Dr. Fries. So he is one of the experts in the field of glycosylation. His lab in La Jolla deals primarily with CDG, and he is really the go-to for these type of disorders. So what are they planning on doing? Well, the plan is to use the skin biopsy from AJ to create induced pluripotent stem cells, which we heard about a little bit already. And from these stem cells, the kind of long-term goal is to potentially have them derive organoids. So those are, you're basically differentiating the stem cells into the different types of tissue, and then forming organoids, which are more like three-dimensional structures that may mimic some of the function of organs in our body. And so we can kind of, at that point, see what the genetic consequence of this disorder, what kind of functional impairment is actually occurring in the different types of tissues. And then, future therapeutic impact. What does this mean? Well, we've heard about CRISPR, gene editing, disease modeling, mutation correction. And all of this is to say that this is kind of where personalized medicine, the promise of personalized medicine, this is where all this data is driving towards. In the future, the hope is that with this type of patient-specific organoids, we can use it to predict individualized drug efficacy and create targeted therapies. So I talk about this as if this is the future, this is all in the future, but even just a cursory look at literature now shows that a lot of this is already happening. I just pulled up a PubMed, search on neuronal like organoids and just to see like what the kind of research is in neurology, and you can see that it's kind of running the gamut of just not only getting to the molecular, the biology, just understanding and the basis for how these genes work and kind of how our systems work and how our brain works, but more importantly, how we can then model it for specific issues such as like inborn errors of metabolism. So kind of getting back to the palliative care that Dr. Moyer started with this presentation. So, so if we look at AJ from, based on our previous data of, she's got maybe 3-month life expectancy based on 2 individuals, the hope is that as new therapies come along and her life is further prolonged, that we are going to continue to play a role in her life. I don't think anyone's under the impression that the research that's being done is somehow going to cure patients like AJ, but it may make it easier for us to provide better quality of life for her. And so maybe we can provide a longer period of time. And as Dr. Moyer mentioned, it's quality over quantity. Hopefully, as we increase the quantity of days, we are also increasing the quality of the days for patients like her. And just finally, tenderness is language children understand best. That's a quote of St. Elizabeth Seton. And that's our presentation. Thank you.